because we're about to move into prevention. You have, that was about, if I may say so, 14 questions in one. But I hope that quite a lot of them are going to be tackled actually by our next session, which is on prevention. So a perfect question. I'm going to say thank you to you two, and I'm going to call up now Paul Breckell, who you just heard from, Chief Executive of Action on Hearing Loss, to talk about early diagnosis. And I hope, Paul, that you'll cover some of those points. And if you haven't had the questions answered, let's, in what he says, we'll come back to it later.
Great. Brilliant. Thank you very much, and good morning, everybody. It's great to be here. So yes, I'm Paul Breckell. I'm the Chief Executive at Action on Hearing Loss. I think many will know us in the room, but for those that don't, we're the biggest charity in the UK working with and for people who are deaf, have tinnitus and hearing loss. And in broad brush terms, we do three things. So we deliver support and care ourselves, a range of both community-based services and some social care provision. We campaign for genuine equality for people who are deaf, and work for changing attitudes. A lot of the things the gentleman that was talking about in terms of people who are for and with people who are deaf, have hearing loss and tinnitus. And finally, we're funding research into technology and treatments, and ultimately to improve those and look for a cure for hearing loss for those that want it. So that's us in a nutshell. Just to give you a bit of context there. But in terms of today, I'm speaking as the chair of the Task and Finish group around early diagnosis, so early action, basically. And again, like Claire said, it's been great to be engaging with partners across the sectors and with NHS England on this. And there's so much still to do. And that's the key point from me. We've done some good stuff, but there's so much still to do. Because we know that unaddressed hearing loss leads to a reduced quality of life. And of course, there's the things that are immediately kind of obvious in terms of communication challenges if hearing loss isn't addressed or adapted for, particularly in terms of groups with background noise. But also, I think we just need to start with the person, start with the whole person. So I stand up here today. Yes, I've got a bit of mild tinnitus and a little bit of hearing loss. But that's not what defines me. It's part of me, but I'm also an employee. I've got a ruined ankle from a football injury. I'm a father, I'm a husband, I'm an out-of-shape cyclist, I'm a slightly depressed Coventry City fan. There's a whole variety of things which define me, not just my hearing loss. Anyway, we're going to Wembley, aren't we, Mark? So I'm not completely depressed. So there's a whole variety of things that define me. It's a serious point made in a jokey way, because I think that that's what we need to think about in relation to the action plan. We need to think about social isolation around the links to depression and dementia. It's not just about addressing the hearing loss. It's about addressing the needs of the whole person. We need to think about what it does in terms of access to other aspects of health and social care. So not just the route to the hearing care professional, but all those other aspects of health and social care when hearing loss might be a barrier. The impact on family and friends and relationships, and of course the issues in the workplace. So you hear a lot about that in later sessions around living well, for example, but I just wanted to put the importance of early diagnosis in context. But only 2/5 of people who need hearing aids have them. Just pause there. I know sometimes that sort of fact, which we use a lot, can kind of just wash over us. We've got a not perfect solution, we know that, but hearing instruments are a great treatment, and we're giving it to 40% of the population of the UK. I mean, what's that all about? What is that all about? So whilst we are right up there, about the 3rd highest penetration in the world in terms of hearing aid use, it's just not enough, and people still wait way too long. And actually, at the moment, there are issues in the system that we know about, and we've been working with NHS England on. So even when people go to their GP, 45% don't get the referral they should first time around. So there's a huge amount of work to be done, even within the allied health professions. Hearing aids do impact on quality of life in a positive way. The evidence is there, and they're the most beneficial when they're fitted early. So all really important stuff. So what have we done so far? Well, a colleague of mine always says, Paul, let's not boil the ocean. Let's not try and do everything. You might have gathered I'm quite gregarious. I want to do everything. But, so the 4 areas of work we're focused on are around universal screening, opportunistic screening, links to other co-morbidities, so other conditions if you like, and then how we strengthen the guidance that's out there on the front line. And I'll just say a little bit about what we've done and about the journey to travel. So in terms of universal screening, we at Action on Hearing Loss, other partners, the Ear Foundation's done a lot of work on this, for example, have been making the case for universal screening and looking at the cost-benefit of it for everyone at age 65, and it would increase numbers of getting help and awareness. So at an estimated cost of 255 million, it would save 2 billion over the same period of time. So it feels to me like it's a straightforward ask. But screening programs are, there are many in the UK, and they are expensive to set up. And if we hadn't already noticed, we're in a decade of austerity. So whilst from my perspective, no, that money would have been saved all times over if we'd have just cracked on with this. There is still an evidence gap to address. And the National Screening Committee looked at it in January 2016, and we've still got some work to do on the evidence. So as a working group, we've been sort of just trying to collate where those gaps are and sort of push that back out to the system, because there needs to be a randomised controlled trial to show the benefits of screening. There needs to be some more academic research into the efficacy and the take-up of hearing aids. So there's work that needs to be done in the wider system to make that case, because that, we think, would make the biggest difference if actually we picked on 65 there just because it's where the economics works best, but if somebody at that stage was actually being proactively encouraged to take a hearing screen in the way you might do for another health condition like bowel cancer or cervical screening, and that would then be that move towards action and make such a big difference to people's lives. So still work to be done on universal screening, but what we've done so far is to try and identify the evidence gaps and next steps. But in the meantime, that doesn't mean that we can't do something. So it's very easy to have sort of an opportunistic hearing screen. So anybody that's not checked their hearing recently, you could probably in the break, you could, if you can get onto the Wi-Fi here, you can go online and you can find a perfectly good initial indicative hearing screen. So you could go to Action on Hearing Loss's website, for example. 1.2 million people have over the last 10 years to take their hearing check. Similarly, you could go to many providers on the high street. So we partner with Boots, for example, as part of their great big hearing check every year. And you can get your hearing check there for free, or you can get referred via a GP. So there are routes to get hearing check now. And there are really good bits of kit available, so effective screening tools like HearCheck handheld screeners. So the kit is there, and it's just about the will and about building it into pathways. And there's already some evidence of use, and we've been trying to build on that good practice within the working group and promote it. So, for example, care home providers undertaking screening, and with 70% of over 70-year-olds having some degree of hearing loss, again, you would have thought it's a very obvious place to start to actually look at that social care community, generic social care community, and to try and have an intervention so people take action in relation to their hearing loss. And there's guidance out there through NICE. So again, it's about sort of joining up these various areas. And again, what we've been trying to push for as a group is more pilots to test different ways of this working. So if I give you an example, at the moment, I don't know what your local GP surgery is like, but when I go in, it's actually quite a nice immediate experience now. The immediate customer experience is I go in, type in, I think, my initials and my date of birth, and ping, up comes my appointment. Because I've got to drive across town, I normally allow a bit of time for the traffic, so I'm normally there 10, 15 minutes early. Now, how difficult would it be if I was there more than 10 minutes before my appointment time for that just to pop up and say, well, why don't you have a hearing check? Right here, right now. You've got an extra 10 minutes. Just move to the screen to your right and take a triple-digit check. It just takes a tablet and access to the internet, all it takes. So I think we really need to think smartly about how we make every contact count within the NHS. On to links to other comorbidities, and this is where we've been doing quite a lot of work within NHS England to try and make those links, because there are certain comorbidities, and they're all there in the action plan, things like diabetes, sight loss, presenting mental health conditions, dementia, where there is an increased prevalence of hearing loss. And there's research that shows some causal links. Sometimes it's actually just showing a correlation, but there's a place we can go to take those opportunities and build hearing checking and early diagnosis into other health pathways as well. So give you one example. If you've got type 2 diabetes and you go for your annual retinopathy check, I mean, again, there's a perfect moment in that pathway when you've had the eye drops in your eyes, you're sitting outside, waiting for your pupils to dilate or whatever happens, and you've got 10 minutes with nothing's happening but somebody sitting in a waiting room normally. Again, a perfect opportunity to have an opportunistic screening check in a pathway where we know there's an increased comorbidity with hearing loss. So we've just got to try and get smart across the system in relation to these things. And we're trying to do some work on that and influence the NHS from within as part of the task and finish group. And we've made some progress this year. And again, there's more to come. And an area where there's been a lot of work, so I want to celebrate the work that has been done, has been around strengthening guidance. So at the very beginning of the day, Fiona made reference to the commissioning framework, and that's such an important document because it gives some guidance to clinical commissioning groups in terms of commissioning hearing services. So very important output already of the work on the action plan. We're just about to launch a bit of work that we've been doing with both colleagues from clinical commissioning groups and from local authorities, as well as a number of the partners in the hearing loss sector, which we've been overseeing as a group, around making sure that joint strategic needs assessments really include hearing loss appropriately, and then we've been promoting that guidance. So just to say a little bit about the JSNA toolkit, which is coming to the internet near you soon. It should be launched, we think, in about May time. And what it does is allows you to look at your local population, a tool that allows you to look at your local population, either by CCG area or by local authority area, because we know that they don't always perfectly match, and have a look at sort of the demographics in terms of who you've got in your patch, who've at what ages, with what degree of hearing loss. So it's a really great little data tool. And that then can be used in terms of service planning. So here's one quote from Wakefield Public Health, who've been partnering with this, and just talking about what a useful tool it is for local authorities and commissioners to make sure that JSNAs have got the right information in. So that's another little step forward to make sure at a local level we really think about making sure that hearing loss is considered in local plans, because if it's in the local JSNA plan and there's some good commissioning guidance, we should see good local services being provided. That's what this is all about at the end of the day, both for early diagnosis and then for good quality treatment. So just to close, whilst there's been some great work done over the first 12 months, for me it's always about the next 12 months. It's always about what we're going to do next, and particularly what we're going to do next for those 4 million people with unaddressed hearing loss who we're frankly letting down at the moment. So we need to push for more research into universal screening. We need more pilots and research around opportunistic screening, and to take the opportunities that are already there to develop strategies around reducing stigma and increasing awareness of hearing loss. And the point the gentleman made, I mean, I will address at least one of them, that stigma is such a complex issue. For me, it's so important that we respect the individual in this. So we respect the rights of somebody who's deaf in terms of their deaf culture. We respect the rights of somebody with acquired hearing loss in terms of getting the right access to technology and treatments that they want. And we put the individual at the heart of this in terms of choice and control. That's what's really important, and because we need a real change in public attitudes, both to make sure that we don't inadvertently put off people from taking the action that they need, but also to make sure we encourage everybody in the UK to really look after their hearing, take early action, and address their unaddressed hearing loss, because it's such an important issue. So thank you very much for listening. Really happy to answer any questions if we've got some time, and it's been good to speak to you today. Thank you.
So, any questions? I thought there's one up here, and for the moment, where have we got the... Okay. Well, let's take this. You've got one there. Good. Lovely. Tell us who you are.
I have. I'm Molly Berry, and I'm the chair of the Association of Teachers of Lit Reading to Adults. Our lip reading and managing hearing loss classes are an excellent way of people adjusting to hearing loss. But the problem that we keep having is that it is entirely considered an old people's thing. And so people in their 40s and 50s don't want to get hearing aids because that's for old people, and I'm not old. We've got to get over the stigma of hearing loss if people are to take advantage of these wonderful gadgets that are here, the modern hearing aids. And I hear time and again that people won't wear a hearing aid because it's an old person thing. But when they come to a lip reading class and they're among other people with a similar problem, they are much happier to wear their hearing aids and to admit to their hearing loss and to get the help they need. So the screening, I would be much happier if it were to start at 55, which would mean that people would be less worried about the age aspect. And I'm sure a lot of those who have hearing loss at 65 did have hearing loss at 55 and would have been better off addressing it then.
Okay, let's
Great.
have your thoughts on that.
Three quick points. Molly, that's fantastic. First thing to say is just to advocate the importance of lip reading as a skill as well. We've focused on the early uptake of hearing aids because that's sort of the NHS sort of bit of the pathway, which is the kind of maybe that first step. But actually it's then the allied support around that in terms of lip reading, around other assistive technology. That's all part of the mix. That's the first thing I was going to say. The second is to absolutely agree with you about the importance of peer support. Now, whether that be through the local lip reading class, whether that be through a local hearing aid support service. I mean, again, I know there's a number of us in the room, Action on Hearing Loss included, who deliver these sorts of services on a community basis. Getting people together actually breaks down some of their barriers and their stigma, whether it be around hearing loss or tinnitus. And so that's really important too. In terms of why 65, not 55, well, we ran the data. I mean, this is was data that was worked together through Action on Hearing Loss, the Ear Foundation, and others at 55, 60, and 65, and the economics slightly stacks up better at 65. Now, I agree with you because the economics is positive in all three ages, and the earlier the better. But you know, one battle at a time. If we can get screening at 65, that would make a big difference, and then. Who knows? Maybe we can chip it down a few years at a time and make the universal program even broader. But it was really a pragmatic call rather than anything else. And to be clear, because I know I'm here with an Action on Hearing Loss hat on and an NHS England hat, I think the key point in relation to screening is making sure we've got the evidence right so that we have an effective universal screening program. I'm a convert in relation to screening, as you can tell, but I mean, we need to work through that process, and that's what we've been trying to do with the NHS England group.
Thank you. Of course, the BBC is doing its bit here for younger people who watch Poldark, and they think it's mumbling. And of course...
And SSGB.
And SSGB, which is even more mumbling. And actually, if you just put an end, it's your hearing, you need to have it checked, not the actor's mumbling.
Bit of both, actually.
Yeah, a bit of both. That would be really good. We get a lot of people that way.
Before we let the BBC off the hook completely, a bit of both. So we work with the BBC to encourage them to think about things like background noise and quality of voice in their production values, because sometimes producers are not quite as good as they should be about thinking about definition. But you're right, occasionally, so it's that sort of thing that does encourage people to take a bit of action too. And it's interesting in terms of how you ask the question. So we find if you ask the question, for example, do you find sometimes the background noise in restaurants makes it really difficult to hear? People are happy to answer that question positively, maybe. Whereas if you ask the question, have you got a hearing loss, you'll get a different answer. So a lot of the stigma stuff is about how we frame the questions. I think that's absolutely right.
And we all know that A to Z, do you remember when A to Zs used to be before internet, and they made it smaller and smaller type, and I'm sure they were in league with opticians. So,
speaking of which.
Speaking of opticians.
Speaking of which, I knew this was our next speaker. Tell us who you are.
Hello, I'm Mark Georgievic. I'm from Scrivens Hearing Care, and I want to talk to you about the National Commissioning Framework. Scriven's Hearing Care provides a service for 100 CCGs, and NHS Improvement and the NHS Framework for Hearing Loss have recognised that as a result of AQP, we have improved access, choice and quality for service users, which are very, very important planks to the National Commissioning Framework. The National Commissioning Framework was published 8 months ago, and it's great that Hammersmith and Southwark are here today, but actually, in terms of new CCGs embracing the National Commissioning Framework, we have seen one CCG in the last 8 months come to the table in terms of developing a new type of service in line with the National Commissioning Framework. So whilst we have a lot to be positive about today, and I think the National Commissioning Framework is very ambitious and it's joined a lot of providers and community together to produce an excellent document, it has had no traction at all in relation to new clinical commissioning groups embracing it.
Who wants to take that?
Yeah, I mean, I can respond, but I think also Fiona probably needs to respond too. So for me, I think the commissioning framework is the first step. But you're right. I mean, I think it's still a very challenging context. So with our experience is that there's been 14 CCGs that have gone out to consult on reductions in service over the last 12 months. 13 have backed off, and I think the commissioning framework's been part of the evidence base which has helped that to happen. One hasn't, which is a real tragedy for people in North Staffordshire. So it's very inconsistent locally, I'd agree with that. But also, as to your point, actually seeing the development of innovative models of delivery. So for me, and I'll hand over to Fiona in a moment, but it's all about promotion now of the commissioning framework, because it's good that we've got it, but it needs to be actively used and promoted regularly. Because we know commissioners, and there's some in the room, are very busy people with a lot of services to commission, and we know hearing care is just one of many, so we just need to keep it in front of people, is my view. But Fiona will no doubt speak to it as well.
Yeah. So I think just to echo really, it is.
No, it's not.
Oh, it's not on? Okay. So the commissioning framework was launched in June last year, and I think it's, as you said, a first step. What we've seen is good engagement from those CCGs that are beginning to look at those hearing services, those 14. They've used the commissioning framework, and I think we would be in a very different position if we hadn't had the commissioning framework. As I said at the beginning, this is about us as champions. This is about every single one of us using evidence that is there. The other thing I think is that it's fantastic to have some commissioners here today, but we know that actually it's going to be about those champions. We made an absolute decision right at the beginning for the commissioning framework to be co-produced. It really was not going to be about us in NHS England sitting in a small room just on our own. This was about gathering what good looks like, gathering the evidence, and also working with our commissioning groups so that actually it was what they needed. So I think that's the bit. That's about working now with the commissioning group so that we spread and adopt. I agree it's early days, but I am a natural optimist like Paul is, and we've got more to do, but there's support from us in the centre and from everybody else in this room, so there's going to be, I think, more of this in the next year. We're working, our team in NHS England over 17-18 as a programme in place for how we're going to get out to the regions, get out to the local commissioning groups so that they know more about the CCGs, about the commissioning framework, but also recognising that it's very challenging in a CCG environment at the moment. So what can we do in terms of thinking more creatively about engaging them, about webinars, about making sure that that evidence is out there. So good start. Really good with the 14 that used it in the first instance to inform their decisions, but more to do.
Thank you very much. And have we got somebody from Hammersmith? Have we got someone at Hammersmith? Just give us a couple of tips about why you took this up and what else do you think might happen?
So we took this up, we were invited to join the NHS England working group, and it was coincidental that our services were coming up for renewal. So, being quite honest, we had a vested interest.
So you were in the right place at the right time?
Yes, absolutely. So going forwards, we've actually managed to roll this out across all of inner northwest London, which we're really pleased about. It's not just Hammersmith and Fulham CCG, there's 5 of us.
Okay, thank you. We had one more question and then we're going to break.
Hi, David Wellborn from the British Society of Hearing Aid Audiologists. We've heard some great stuff today. We've worked hard on making the progress that we have made. but it's actually 22 years since the World Health Organization had its first resolution on hearing care. They're about to issue a resolution this year, and I'm interested to know what the UK government's attitude and promotion of that will be. It's 10 years, this is the 10th year of World Hearing Day. It's the first year that I'm aware of that we've tried to make a big deal of it in the UK. Europe's been much more ahead of us. It's 2 years almost to the day since the publication of the action plan on hearing loss that had neither action nor plan within it. It had intent. That intent is great. But actually the reality is very similar to what Mark's identified, that it feels as if nowhere near as much is happening as the great stories that we're telling ourselves. We need to be promoting much more widely all of the things that we're talking about, not just amongst those who are part of the in crowd already.
A point well made.
I mean, I couldn't agree more. My wife would tell you that I'd love to be able to speak for the UK government. That would be my dream gig, but sadly I can't. No, I know. Sadly I can't. But I think the point's well made, David. That this is about a collective effort, and there's so many advocates in the room to promote this. Whether it's people who are deaf, have a tinnitus or hearing loss, whether it's clinicians, professional societies, providers from all sectors. We've got a real job of work to do to make sure that there is both a plan and action.
And also, might I suggest, coming from the outside as I do to you, that actually it's about pull, not just push, in that then actually gets people to say, we want this, and it's important to us. Because actually, if you haven't got enough people shouting, then you're quite easy to ignore. And it's the population that needs to know that this is really important.